Welcome to RSSDI TV 2020. I am Dr. Shahu Ingole and you are watching me on RSSDI TV brought to you by Vocard. Today I am honored to have with me an eminent personality and renowned senior diabetologist Dr. Anant Nigam sir. Sir is the director, Nigam Diabetes Center, Jaipur. Welcome to the show, sir.
Thank you.
We all know that in spite of the plethora of anti-diabetic medications, more than half of the diabetes patients they remain uncontrolled, and early intensification is always advisable to prevent the macrovascular and the microvascular complications. To discuss this in more detail, we would like to know from you, sir, why and when does the primary therapy fails in type 2 diabetes mellitus patients?
Well, doctor, you know that type 2 diabetes is a progressive disorder. That's the first thing to understand. And there are studies to show very clearly that by the time the patient reaches the doctor, about 50 to 60% of his beta cell function has been lost. And there are also studies to confirm that about 5 to 6% of these beta cells are lost every year. So if somebody's got diabetes for 10 years, he's lost almost all of his beta cells. So the bottom line is type 2 diabetes is a progressive disorder, and so any prescription that you wrote 5 years back may not hold true in 2020. And therefore, from time to time, his prescription has to be revised. Data very clearly shows that about 40 to 50% of people will require intensification of therapy at about 5 to 6 years because of the progressive nature of disease. And this sometimes is needed with injectable therapies because oral drugs in all combinations, dual and triple, will start failing by 5 or 6 years in most of them. Of course, with the arrival of the DPP4 inhibitors, the SGLT2 inhibitors, the story has changed what it was before the advent of these newer anti-diabetic agents. But still, because the disease is running faster than you'll probably require some injectable therapy, or at least a couple of people out of 10 will require an injectable therapy for optimal control.
Okay, so sir, what should be the right perfect timing to initiate the injectable therapy in these type 2 diabetes mellitus patients who are uncontrolled on OADs?
Right. So, let me talk about 10 years, 15 years back when you didn't have the GLP-1s, when you didn't have these newer agents, then it was said the earlier the better. And still, I would say, I wouldn't like to use the word earlier the better. I would like to use the word timely is important. When do you initiate injectable therapy? So timing is the critical factor because that is the time when you really, your judgment, your clinical acumen really counts. And if you initiate on time, then you're doing good service to your patient by preventing complications as you just mentioned. Now, when is the critical time? And that critical time is decided on a number of factors. It is decided on how your HbA1c looks at that point of time. The general consensus is that if your HbA1c is about 1 to 1.5% above the target that you set for your patient, that's the time to really think, talk to your patient, and initiate an injectable therapy. Because, at that point of time, something is really going wrong. And that golden period should not be missed. That golden timing should not be missed. And if you are able to really hit the patient beta cells, just get the glucose toxicity down by improving his control with injectable therapies. Maybe the patient comes back on oral tablets after a couple of months or maybe a year. But then that is the time when you should wait, when your HbA1c is in that range. Now, there will be patients where HbA1c is 3%, 4% above the target. That is surely the time when you need an injectable therapy.
Okay, so sir, what are your recommendations for initiating the insulin therapy or injectable therapy in such patients, sir?
You see, as I mentioned, about 10 years ago, you just had the choice of insulins to initiate injectable therapies. But the story has changed in the last couple of years. I would place it as an endocrinologist. I would say I have a glycemic reason for initiating injectable therapy. Second, I have a non-glycemic reason for initiating injectable therapy. Let me first talk to you about the non-glycemic reason. Hard evidence is available with all the CVOT trials with the GLP-1s, which very clearly show that if you have atherosclerotic cardiovascular disease, then the first agent of choice is a GLP-1 agent. And that's an injectable therapy. It not only controls your glucose, but is also preventing you, or also helping you look after the atherosclerotic component of. So that is one very important agent. And the title of my talk says moving from orals to injectables. And that is the time when I would probably stop one oral agent like a sulfonylurea or a DPP-4 inhibitor and put the patient on a GLP-1. So I've moved from an oral to an injectable for a reason that is not glycemic. His HbA1c may be 7.5, but he's had a MI. He's got a bypass surgery done maybe last 3 months back. So that's the time to really advocate GLP-1 therapy. Now you've got the glycemic region, glycemic reason of initiating therapy. And there the dictum now is that you should try and convince the patient to use the GLP-1 prior to insulin in most situations. What are those special situations? If your HbA1c is about 2% above normal, and you know that he needs injectable therapy, then you should advise a combination of GLP-1 and insulin. If that's not the case, then a simple GLP-1 is fine to initiate therapy. Why am I choosing a GLP-1 versus insulin? That's the next question that comes to your mind. Well, the GLP-1, in addition to being as powerful an agent in reducing HbA1c as insulin, also helps you lose weight and has little risk of hypoglycemia. Something that insulin has in front of us, and where you need real good education to look after hypoglycemia, to look after weight gain with other agents. You've got to stop weight with other agents when you're using insulin. So that's the first important thing. Now, if you have a compelling reason for hypoglycemia, then of course GLP-1 will be the choice. But suppose somebody presents to me with an HbA1c of 11, 12, and he's got symptoms of catabolism, he's got symptoms of weight loss. I'm going to use insulin first. So I always choose based on the patient's profile. Somebody presents to me with 12.5. I know this fellow needs a GLP-1. I first give him, and he's got weight loss, etc., etc. The last 3 months, he's lost maybe 5 kilograms of weight. I'll first give him insulin, get him to reasonably control about 9 or 10, and then maybe add a GLP-1. Take away one drug, add a GLP-1. But otherwise, a GLP-1 is supposed to be an agent that you should consider talking to your patient, because cost is the major issue there. And if cost is not an issue, then probably some patients will accept a GLP-1.
So, sir, while moving from oral to the injectable, how important it is to spend time with the patient and do the counseling of the patient so that we can ensure insulin adherence?
Well, that's the critical part, actually. Education, whenever you're talking of any chronic disease, I would say not only injectables. When I'm talking to a new patient who's got type 2 diabetes, I spend a lot of time in educating, letting him know that it's a progressive disorder. So your prescription is going to change in the next couple of years. And people otherwise, think that this prescription is good for the next 5 years. No, that's not it. It may change after 6 months, may not change for even a year, depending on how the patient really gets disciplined after having diagnosed with type 2 diabetes. So education is very important. I would also consider patient empowerment as extremely important. You've got to teach patients how to do self-monitoring of blood glucose, how to titrate. It's not only important to initiate insulin, it's also important to up-titrate insulin, because that is a very important factor. Then the hypoglycemia is a very important barrier. Any injectable therapy, the first thing that comes to the mind of the physician and the patient is, I'm going to get hypoglycemia. So you've got to tell the patient, if he takes the GLP-1, he's probably not going to get into hypoglycemia unless he is already on SUs. So there you've got to really decrease the SUs or stop the SUs. If your HbA1c is about 8.5, I wouldn't even add a SU, because the GLP-1 is going to take care. But otherwise, if the patient is on insulin, you've got to really readjust doses of insulin. You've got to, if your patient can afford, use the newer basal insulins like glargines. Now you've got the next generation basal insulins, like a U300 glargine. Now, what's the advantage of U300 glargine? It's going to have better risk. The risk is lowered when you're titrating down. And when you get hypoglycemia, you get hypoglycemia during the titration phase. So that's where the U300 type of insulins, the next generation, will help with little risk of nocturnal hypoglycemia and anytime hypoglycemia. So it's a complex situation, but I think empowerment, education, and really talking to the patient, spending time to the patient on each visit, I think is going to be of paramount importance.
Thank you so much, sir, for sharing your views and joining us on RSS Day TV brought to you by Vocard. Thank you so much.